Thank you. My goal today is to talk about testing of patients and healthcare workers in this most rapidly changing area. Over a year ago, we were faced with this pandemic. We didn't know it was going to be a pandemic, of course. Marching forward 1 year later, there are almost 100,000 publications in PubMed on COVID-19. There are almost 5,000 clinical trials on clinicaltrials.gov on COVID-19. And there are over 400 tests available at our disposal to test for COVID-19. It's a rapidly changing area. This is a figure of what we have now come to realize is all too common. That is the phylogenetic tree of COVID-19 or SARS-CoV-2, the clades or the groups of virus that have originated from a common ancestor and how they have marched forward over the course of time. Those clades depicted by the colors in the maps on the right highlight the fact that we have different strains all over the world. RNA virus is a rapidly changing, rapidly mutating virus. And we'll come back to this point on its relevance, of course, for testing. But because of genetic sequences, we have certainly begun to understand how changes in this virus have affected this particular pandemic. Some of those changes have brought on evolutionary advantages, as we know, in certain parts of the world, like in the UK and Brazil and in South Africa, and now, of course, in the United States. So we have been faced with the challenges of testing and now I would say the benefits of testing since the beginning of this particular pandemic. We can now ask the question, what kinds of tests should we use? Which ones are fast? Which ones are accurate? Which ones do we need to use to determine who to admit to a hospital, who to administer a vaccine to, who's negative so that we can send that individual to school or back to work? Testing is the foundation of this particular pandemic, and that's what I hope to cover with you today. So let's begin over a year ago when in Boston, there was an outbreak after a biomedical conference. At that time, because of a lack of testing, rapidly we at least realized that this particular outbreak affected about 20,000 individuals. Now, fortunately, those individuals at the conference had samples stored. Those individuals migrated back to the States as well as back to Europe, where they were from. And in retrospect, following specific variants, in this case, the C2416T variant, we've now realized almost a year later that this particular outbreak was responsible for at least 300,000, if not more, individuals getting infected. The power of testing was not with us at the beginning of this pandemic. It certainly is with us now. Early on, academic medical centers in general, had to figure out what kinds of tests should we use, which ones had accuracy, which ones had high throughput. On the left, I highlight the time scale of the large platform companies and their releases of the tests that received EUA approval. Below that, I show you our two academic medical centers when we were able to put forward laboratory-developed tests. In fact, they were in concert with some of these large platform companies, and that's because we have a large research portfolio as well as investigators that were able to stand up these tests. The point here is that testing, of course, has exploded in terms of being widely available. The picture on the right highlights another point that I'd like to come to, and that is the relationship of academics and industry, and of course, then with government. As I just mentioned to you, the outbreak from the Biogen conference in the slide before, well, the slide on the right demonstrates a team that we have here at Mass General Brigham working hand in hand with Biogen where we actually put out a call for PCR machines, and they were gracious and generous enough to loan us some PCR machines. We brought them back to our organization, and that allowed us to have high throughput testing early on in the pandemic. Relationships that otherwise would have never took place were it not for this pandemic has been one of the silver linings, certainly as a result. Well, there are many different tests, molecular tests, antigen tests, antibody tests. Over the next few slides, I'll highlight how testing has changed. But just to put something in perspective, and that is about a year after the pandemic began, we have over 250 PCR tests that have received EUA approval, over 60 serology tests, several dozen antigen tests. What have we learned from these tests? Well, we've learned that early on, some of these tests were not ideal. For example, we were challenged with false positive and false negative rates. But what we also learned is that because of the ingenuity of those individuals developing tests, we were able to develop tests that were more accurate, gave us results in a shorter amount of time, and in fact, the cost came down. The speed at which tests were released allowed incremental changes to occur, each which, of course, improved on what was there before. And we, of course, as a society, have benefited from that. So while testing was a challenge early on, we've realized that industry, academics, of course, the government as well, all over the world, have now allowed us to find the ideal test in the ideal setting, hopefully at a lower cost, hopefully at high speed, and hopefully with immense accuracy. So what have the needs been for testing? Well, early on in the pandemic, we were very interested in who was positive. We were willing to make a mistake, but those individuals had to be admitted. Those individuals had to potentially be intubated. Those individuals had to be removed from infecting other individuals. Later on in the pandemic, we asked a more important question at the time, which was who was negative. We needed accurate tests to determine who was negative so we could send individuals back to school, back to work. Potentially, we could open up restaurants and other facilities. We were doing massive testing in non-acute facilities. And now, almost 1 year later, the needs of testing have changed because we want to know among those individuals, for example, that have received a vaccine and have demonstrated a slight illness, can they get infected? Can they transmit the infection? We needed to know who we should try experimental treatments on. And so as you see during this pandemic, not only has testing been the foundation of managing the pandemic, but our needs for testing have changed. We have used testing to fit our needs. And fortunately, given the number of tests and the kinds of tests we have, we've been able to take advantage of the diversity of tests. Here's an example of the challenges early on in testing. How did testing change? Well, our epidemiology changed as a result of testing. On the top right, you see a map diagram of testing in Massachusetts. Back in May, of course, there was a spike of cases. And then we marched forward, July, September, and so forth, and realized that the cases that we have in January are almost triple the number of cases that we had back in May. But if you look at the bottom panel, what you realize is that the amount of testing we did on a daily basis was very different early on. Early on, we tested those individuals who were sick. Later on, we realized that we should be testing everyone, especially those individuals that were not sick or those individuals that were asymptomatic. We know that at least 50% of transmission occurs in the asymptomatic groups, but people wanted to know later on in the pandemic who was negative. And as a result, you see the number of tests going up almost exponentially over time. as you see through this red arrow. And so, do the cases that are presented now in Massachusetts in January represent, in fact, a similar metric as what we saw back in May, or were they as a result of just more testing? It's probably a combination of the two. This chart, almost can be considered an eye chart for that matter, highlights the fact that there are different kinds of tests. There are different needs. There are different types of devices. When you look at the requirements of testing, whether it be sensitivity, specificity, how fast did they yield results? What is our supply chain? These are the kinds of calculations that we as a medical center and as a community had to go through. That calculus of balancing speed versus accuracy, the calculus of trying to figure out cost and supply chain needs. And put all together, the good news is we now have tests that can be used in certain circumstances. Maybe we're okay using the rapid tests that are less expensive in certain settings when the disease frequency is low. Whereas in other settings, when we need really sensitive tests, we need to use perhaps more expensive testing like PCR. And that's what we've learned during this pandemic. Massachusetts, which is where I'm from, is the home of over 100 colleges and universities. And this is a heat map to an extent of the positive testing rates among those colleges and universities in the fall of 2020. Colleges and universities wanted to bring students back to school. They had to scramble to figure out where could they get testing? How frequently should they do testing? And what was the cost of that testing? Could they bring their students back on campus? Huge challenge. And in Massachusetts, especially, given the number of colleges and universities, we had to figure out how to manage this challenge. Well, fortunately, given the academic foundation, we have a number of large centers that can perform PCR testing and testing overall. I was part of a group that put together a guidance document for a testing strategy that, in conjunction with the governor and the state, was able to guide colleges and universities in terms of testing. Now, testing, of course, and the guidance on what we provided was based on quite a few assumptions. We know a lot more about the disease today than we knew back then. Nevertheless, we relied initially on model builders. Now, of course, the British statistician George Box reminds us that all models are wrong, but some, of course, are helpful. But what did these models tell us? Well, the input for many of these models was an assumption of how many individuals were asymptomatic and how many were symptomatic. What was the sensitivity of the test and what was the specificity? And more importantly, what was the R0 in the community? With those as the input for these tests, what we were looking for was how frequently should we test to contain the level of infection at the time in our particular community. And here's an example of an output of that testing. The top left, you see the large space of gray representing false positive tests. What does that mean? It means when the R0 is relatively low and you do daily screening, a positive test most likely is a false positive test, provided you do the daily screening. And again, the R0 is low. In contrast, when the R0 is low and you do screening every 3 days, the number of false positives, again, that gray space, gets narrower, and the number of true positives go up. What was quite striking from these models is that when we went to weekly screening, you realized that there was no way we were going to contain this infection, this pandemic, even if the R0 was low. You see there is really no false positive rates. You see that weekly screening doesn't contain the infection and it just goes up almost exponentially. Here's the same kind of analysis when the R0 is higher. And here, even more of a challenge. Daily screening, when the R naught is higher, again, same test specificity and sensitivity, at least daily screening allows fair control of the infection. However, when you look at every 3-day screening, you realize that there is no way we would control the infection. The number of true positives just continued to go up. And finally, when the R naught is high, and if one chose weekly screening, you realize there's really no containment of the infection. In fact, the number of cases goes up and goes down primarily because of herd immunity. At that point, everyone in the community gets infected. So it's these kinds of models that we used to ask the question, how frequently should we test students that come back to colleges, to their dormitories, to boarding schools, of which, again, there are many in Massachusetts. And not surprisingly, depending on cost, convenience, logistics, operations, universities and colleges adapted slightly different strategies. Fortunately, at the time when we began this, the R naught in the community was low. So we could have a debate on, in fact, even what kinds of tests to use. But I'll go back and remind us, this was now August, September, the fall of 2020, and we were mostly interested in who was negative. Who could we send back to school? The changes, in January, of course, we needed different testing, or at least a different strategy, because our needs changed. But at least in the fall in our community, the biggest question was who was negative and how could we open up the schools again. In this paper from the New England Journal, it nicely highlights a few key points. The first one is, let me just orient you. The x-axis is the chance of infection before a test result is known. It's the pre-test probability. One can simply think of this as the R naught. When you move from left to right, the R naught goes higher. One simple way of looking at it. On the y-axis is the chance of, is the post-test probability, the chance of having an infection with a negative test. Now, of course, that squarely focuses on sensitivity. So the two lines represent two kinds of tests, one with a sensitivity of 70% and another one with a sensitivity of 90%. 70% sensitivity, in other words, is a 30% false negative rate. And 90% sensitivity is a 10% false negative rate. And what you see here is that depending on the type of assay needed, your ability to contain your infection changes. The first observation, of course, is regardless of the sensitivity of the assay, as you move from left to right on the x-axis, no matter how sensitive you have as a test, the chance of having a false negative is really low because the higher the R naught, most people are infected. So it doesn't matter what kind of sensitivity you have. But if you go down to the left side of this figure and find those communities with a low R naught, a low chance of infection, then in fact the kind of test you use, the sensitivity, in fact, matters. If you use a test with a low sensitivity, or 70%, or for that matter, 90%, it doesn't matter about the accuracy if the R naught is low. In fact, the chance of a false negative is low because the R naught is low. And you can actually contain the infection regardless of the accuracy. In contrast, as that R naught starts to march up, the penalty for a false negative goes up. And the need for a higher sensitivity test increases. So it's these kinds of calculations with a focus, a spotlight on test characteristics that led our community and others around the world to ask what kind of test would we need for what kind of circumstance. There's a phrase, and that is fit for purpose. Does the test we have fit the purpose that we need it to deliver? And again, much of it depends on why are we doing the test as well as what the infection rate is in the community. Well, here's a real live example of how our needs changed if you look at the fall of 2020, the colleges and universities opened. But importantly, the R naught in the community was actually quite low. And the debate we were having was, why do we need a very sensitive test? I just showed you a figure that highlighted the fact that if the R naught is low, whether the sensitivity was 70 or 90%, you could still contain the infection. Well, little did we realize that, in fact, the R naught was increasing. And as the R naught, as you see, going from the green dip there with the big arrow now to the red, as the R naught was increasing, we began to realize that we better focus on the higher sensitivity test. Unfortunately, at the time, the more costly test, because the penalty for a false negative was higher. Imagine telling a college student that she could go back to her classes because her test was negative, but the false negative rates were high, and she would then infect other classmates, the teacher, and so forth. And so as the R naught was changing in the community, our testing needs changed. We also began to identify risky behavior, the clusters, the bringing together of individuals, whether they were coming together in restaurants, in cafes, in the dormitories, or and the cafeterias. This was the new definition of a risky behavior. Well, we did a pretty good job, I would say, in Massachusetts of containing the infection. That said, the newspapers, of course, highlighted that we had outbreaks. And here's a list of some of the outbreaks, but certainly not an inclusive list of all the communities, colleges, and universities that had outbreaks. There were certainly more than the ones listed here. But we developed a strategy in July and August, and already by September, as the R naught was increasing, so too were the clusters in the colleges and universities. And while they were contained and colleges stopped gatherings temporarily, set curfews, set restrictions, nevertheless, we weren't able to contain the infection entirely. Well, these clusters were not restricted to colleges and universities. We had cluster outbreaks in hospitals. We certainly had cluster outbreaks in healthcare communities, whether they were nursing homes or other healthcare facilities. We had to, in our organization, declare or attest on a daily basis through a pass that we were asymptomatic. Now, that pass, of course, has changed, fortunately, because not only do we declare now that we're asymptomatic, but as you see the pass on the right side, that, in fact, it also tells us when our vaccines are going to be administered, and as a reminder. And this kind of these kinds of apps or tools were becoming more commonly used to attest for symptoms. But we also know, of course, that asymptomatic infection is actually quite common. That said, the restrictions we put in place could not contain the infection entirely, especially as the R naught went up. And as I showed you early on, that in January, it has reached a peak. Many studies began to highlight the kinds of behaviors that were linked to cluster outbreaks. And no surprise, it's the ones we know, whether it be restaurants, bars, and coffee shops. This is the red dots looking at the odds ratio for COVID-19 infection, published here in MMWR in a case control fashion. But this is just a depiction of one study that necessarily represents many other studies. You can replace restaurant for cafeteria or dormitory. You can replace bars and coffee shops for small or cafes and gatherings of individuals. These were the risky behaviors, and the R naught in the community dictated what we saw. We couldn't keep up, of course, with the testing, not only because of the logistics, but also because of the cost. So we come back to this phylogenetic tree, where now a year later, this is just a highlight of some of the largest clades, again, the families of viruses from the colors that you see here. By January, we know that the B117 variant accounted for more than 60% of all infections in London. And where does that show up here? Well, on the top right, you see a cluster, a bunch of blue dots. And that represents this new variant, the B117, which has more than 20 different kinds of mutations. And these kinds of clusters now we're beginning to see in different parts of the world with a variety of variants, whether it's the South African variant, the Brazilian variant. Just recently, there was a study that highlighted a variant that was unique to California. And that is not going to be uncommon. But let's come back and ask the question, first, what do these variants do? And secondly, what does that mean for testing? Well, just a short tangent to highlight an example of what these variants do. The B117 mutation has the B117 variant has over 20 different mutations. I just circled two of them here, the HV69 to 70 deletion, which is a 6 base pair deletion at the spike amino acid position 69 and 70. The N501Y mutation, also part of the spectrum of mutations in the B117 variant, is a change from asparagine to tyrosine. Well, these two particular mutations appear to play a huge role in terms of the transmission and the infectivity. On the right side, what you see is a ribbon figure of the ACE2 gene, which is the curled figure on the top, and the virus below that, the virus spike protein below that. Let me highlight a few points. First, there are 6 binding sites between the spike protein and the ACE2 gene. They have to fit perfectly. It's almost like the space shuttle docking onto the space station. There has to be a perfect fit in order for a successful transmission to occur. One of these areas, the N501Y, as you see here circled, highlights the fact that there was such incredible connection and affinity that it should not surprise anyone with such tight binding that you probably needed a lower dose of a viral load in order to get infected. And that's how these mutations lead to a higher rate of infection, a higher rate of transmission. With a lower dose and a higher binding affinity of the virus and its docking site, in this case, the ACE2 gene, we now know that there is much more successful transmission. We continue to debate if this leads to a higher rate of hospitalizations, a higher rate of mortality, but we're beginning to see some evidence of that. Okay, with that tangent, let me end and ask the question what I began this talk by addressing, and that is what's the relevance of this mutation to our testing strategy? Well, here is an example on the top of the kinds of platforms that we have at our organization of PCR testing. As you all know, PCR has become the standard part of our nomenclature and conversations today. So here are the different platforms that we use in our organization: Cepheid, BioFire, Roche, Thermo Fisher, and so forth. And as you know, the PCR works by different probes. The probes are what is used to detect the virus specifically, and that's what ends up yielding a CT count. And that count, if it's low, means that it requires fewer rounds of amplification to yield a positive test. Well, let's look at the probes that each one of these platforms uses. For example, the Roche assay uses the E and the ORF probes, E in this case meaning the envelope and the ORF the non-structural region. But here was our challenge. The Thermo Fisher platform, which is what we used and continue to use in our organization quite widely, had a probe on the S gene. That's the gene that obviously there was a mutation with, the spike protein gene. And it turns out that the probe looking at the S gene was at the exact location of the mutation. And now what we're seeing when we measure or try to detect the virus using the Thermo Fisher platform, we see what we call S gene failure. That is, it's not able to detect the S gene because of that mutation. And that changes our ability to determine if a PCR test, is positive or negative if the variant is in our community. It turns out we've now detected it here. In fact, it's in over 20 different states in the United States at this time, and likely more. It's just that we're not testing frequently. But imagine as more and more variants come to place and become circulating, continue to circulate in our community. Well, we now have to begin to look very closely at what kinds of PCR tests that we're using. What probes are critical for those PCR tests? And do those probes look at regions of the virus that have mutated, and are they detecting them well? It should not surprise anyone that while we're noticing an S gene failure on one platform today, there may be a mutation on another part of the S gene, the spike protein, that affects the other platforms like BioFire, or a mutation on the envelope protein that might affect the Cepheid assay. And so testing will have to go under yet another evolution to accommodate the variants, of which, of course, are spreading quite widely in the world. So let me end and ask the question, have we turned the corner in the pandemic? Certainly the vaccines have given us hope. We've had to address issues of supply chain, cost, accuracy. We've had to ask the question of fit for purpose. Is it the right test in the right location at the right time? Do we continue to test asymptomatic individuals? One of the challenges we had were, can we bring into our system rapid test, on-site testing? And little did we realize that because those testing platforms on-site, even though they yielded a result in a few minutes, they were not linked to our electronic health records. And so we could actually not keep track of our employees and or our patients. And so we obviously opted not to use them in our community. But that doesn't mean we can't use those kinds of tests, let's say, before one boards a plane or before one enters into a restaurant. Will testing diminish? I suspect not for the foreseeable future, likely not until we achieve herd immunity. We'll continue to test. In fact, in our organization, we've given well over 100,000 shots of vaccine, but we continue to test just as vigorously. And so testing is not going away. But we'll continue, fortunately, to have at our disposal PCR, antigen, as well as antibody tests. And again, using them in the right circumstance at the right time. So thank you very much for your attention. Testing is the foundation, the key to this pandemic, not only understanding it, not only developing therapies, but helping us come out of this unfortunate worldwide challenge. Thank you.